welcome to the Psychiatry and Psychotherapy podcast, with over 32,000 mental health professionals listening every episode. Why? Because we need to stick together to survive the mental health field. I'm here to talk about getting rid of burnout, increasing job satisfaction, and feeling like an expert in what you do. All right, welcome back to the podcast. I'm here with Dr. Michael Cummings. He's been on several episodes, an episode on psychopathy, schizophrenia. We did a series on psychopharmacology, the basics. And today we're going to do a deep dive into clozapine. It is an antipsychotic drug for treatment-resistant schizophrenia. This is going to be an episode more for the practitioner and for the serious, curious listener, but we're really going to go into a lot of the details. We're going to talk like psychopharmacologists. And yeah, so Dr. Cummings.
Hi, I am indeed happy to be back and also happy to talk a bit about clozapine, one of the most unique drugs currently in use in psychiatry. It actually was almost missed as a psychiatric drug. It was synthesized in 1958, only 8 years after chlorpromazine, the first antipsychotic. At the time, they were testing for antipsychotic compounds by taking a candidate compound and seeing if mice essentially developed dystonia and developed catalepsy. Clozapine does not cause stiff mice. Instead, mice only get sleepy. And consequently, it was almost missed. If it had not been for the fact that two other aniline group antipsychotics, perlipine and loxapine, had been successful, odds are it would not have gotten further testing done. As it turned out, though, eventually it was discovered to be more effective than other antipsychotics.
So cataplexy in cats, I love it.
Mm-hmm.
Yeah, it is sedating. So tell me where it went from there. So they found it, they tested it.
They found it in the early and mid 1960s. It produced positive data first in Austria and then in Germany, and was approved first in Austria, then in Germany, and then in Finland between 1972 and 1975. It was clearly more effective than other antipsychotics, and had it not caused severe neutropenia in a group of 16 patients in Finland, odds are it would have taken over the antipsychotic market in Europe. Half of those patients, however, died, which led to clozapine being withdrawn from the world market. It did not make it into the U.S. pharmacopoeia until it was approved by the Food and Drug Administration in 1989, largely as the result of continued work in New York by John Kane and his group, looking at clozapine's efficacy compared to other antipsychotics.
Wow. And what did they find that in their initial studies, what did they find?
Essentially, what they found was that if you strictly define treatment resistance, that is, the person has failed 2 other antipsychotics that were given for at least 6 weeks at a minimum of 600 to 1,000 chlorpromazine equivalents, and the person then also failed a prospective trial of haloperidol, 15 milligrams a day, the odds that they would respond to clozapine ranged from about 50% to 60%, while the probability of an antipsychotic response to other drugs was between 0% and 5%, with an average of right around 2%, meaning other drugs in a truly treatment-resistant schizophrenic population had essentially a 98% failure rate.
Wow. And that's really hopeful, actually, because, 2 antipsychotics in, you're starting to wonder, okay, is this person going to get stuck in this psychosis? And it is truly miserable to get stuck in psychosis.
Well, indeed, those numbers have largely held up in truly treatment-resistant populations. There's a group, Howes et al., who in 2017 published criteria for treatment resistance, which largely followed Kane's original criteria, except that they don't include a prospective trial of haloperidol, largely because most people clinically are not, of course, doing a research trial. But essentially, it's very similar. If the person has truly failed 2 adequate trials of antipsychotics given adequate dose, adequate duration, with measurement of plasma levels to assure adherence, then the odds that they will respond to anything other than clozapine is basically 7% or less, while the response rate to clozapine remains in the 40% to 60% range. There have been meta-analyses published in recent years suggesting that clozapine was not more effective than other antipsychotics. A criticism of those studies, however, was that they included data from studies that didn't use any definition for treatment resistance. And consequently, it was very likely they were including schizophrenic individuals who were not treatment resistant. And indeed, in that context, clozapine is not more effective as an antipsychotic than other drugs if the person's not in that treatment resistant category.
What do you think in terms of the studies like Cochrane, the meta-analysis that Cochrane have done? Do you think that those are making the same mistakes about the treatment resistance, or?
They have tended to, largely because, as you know, Cochrane analyses typically look at studies that have been published. An area that they did not pay adequate attention to in selecting which studies they would analyze was, did the study do a good job of defining treatment resistance? Clozapine does have benefits other than treating psychosis that are unique to it. However, as an antipsychotic, if the person is not treatment resistant, then response rates are about the same as for other antipsychotic medications given at adequate therapeutic doses. Other unique effects of clozapine include suicide reduction that's independent of its antipsychotic effect, reduction in violence that's independent of its antipsychotic effect, reduction in criminal behavior, and an ability to treat some rather unique conditions like psychogenic polydipsia, and also refractory mixed bipolar states. So it's clear that clozapine is different than other antipsychotics, both in terms of treatment resistance and in terms of the overall range of things that it is capable of treating.
Talk to us about the mechanism of clozapine and why it has different effects from the mechanistic perspective.
All of the first-generation antipsychotics are dopamine antagonists. That was their mechanism of antipsychotic efficacy. The R squared, or the variants, D2 blockade accounted for 92 to 93% of the variants of all of those antipsychotics. And frankly, when anything in science, when you get to the point where something accounts for greater than 90% of the variants, you sort of pack up and go home because there's nothing else major to discover. The second generation antipsychotics are still by and large dopamine antagonists, but with the ability to actually assist dopamine signal transduction in the frontal lobes as opposed to impairing it everywhere, by virtue of their ability to antagonize 5-HT2A serotonin receptors. The partial agonists are, of course, just what their name says. They partially agonize dopamine receptors, but they're still modulating dopamine as their primary antipsychotic mechanism. Clozapine is different from all of them in that it likely provides little or none of its antipsychotic efficacy by altering dopamine signaling. Even at robust plasma concentration, clozapine's occupancy of D2 and D3 dopamine receptors is only about 30 to 40%, below those levels that are typically known to have an antipsychotic effect. Those are more like 60 to 80%. Instead, it appears very likely that clozapine exerts its antipsychotic efficacy by modulating glutamate signal transduction, particularly in the frontal and temporal lobes. Essentially, glutamate is the brain's primary stimulatory or on neurotransmitter. And one of the major characteristics of schizophrenia spectrum disorders is hypoactivity in neural circuits in the frontal and temporal lobes. Improving glutamate signaling appears to be associated with a reduction in positive psychotic symptoms as well as improvements in negative and cognitive symptoms, something else that distinguishes it from the first generation drugs in particular, which may actually worsen negative and cognitive symptoms.
Yeah, that is so amazing. And so the frontal lobe seems to be lower in activity, and I'm wondering also if that has to do with the prodrome of schizophrenia. Often years leading up to schizophrenia, there's more social isolation, a little bit more socially aloof.
Well, as we've touched on before when we talked about schizophrenia, essentially the data would suggest that Kreplin was right when he characterized it as dementia precox. It really is a developmental dementia in which there is not only abnormal neuron migration, but then there is an ongoing excessive loss of neurons and loss of synaptic connections that results essentially in a brain in which dopamine activity is excessive in the temporal lobes, which likely results in the positive symptoms of psychosis. But the frontal lobes are hypoactive, leading to cognitive deficits and negative symptoms.
Mm-hmm.
Clozapine is relatively unique in its ability to essentially get the frontal lobes to awaken and to then do their job in terms of modulating the activity of the temporal lobes.
Yeah, and I've seen that in clinical practice, whereas some of the other heavy D2 blockers can actually make people a little bit more blunted. Clozapine doesn't have that effect.
No, it doesn't. And in fact, as we mentioned, one of the chief effects of clozapine is to reduce violence, which is something is of interest in forensic hospitals like Patton. It appears to do that. A study by Karosky et al. Essentially found that when they randomized not treatment-resistant but just violent schizophrenic patients to either olanzapine, haloperidol, or clozapine, the decrease in PAN scores, the psychosis scores, was about the same across all three groups. But the level of violence dropped dramatically more in the clozapine group, and what that correlated with in terms of psychological testing was the clozapine group had a significant increase in executive functions, which are, of course, mediated via the frontal lobe. These people could think, they could consider, they could weigh consequences, and if someone's brain is more able to do those things, it is less likely they'll resort to violent behavior.
There's something about that doesn't make sense to me because of how anticholinergic clozapine is. And I'm wondering how you make sense of that, because normally when we put someone on like a Benadryl or something, that's not like their full mind there. They're not thinking as critically, their sensorium goes down.
Yeah, you would think that, especially given how anticholinergic clozapine is. For those who want a comparison, 100 milligrams of clozapine exerts about the same anticholinergic effects at muscarinic receptors as 2 milligrams of benztropine. So say if you have somebody on 500 milligrams of clozapine, that's the same as putting them on 10 milligrams of benztropine. For most people, that would be an intolerable impairment in terms of memory and cognitive functioning. It appears with clozapine, however, that the positive effect on glutamate is so robust that it just overrides the anticholinergic effect of the drug in terms of cognition and executive functioning.
Yeah. So do you think also people get used to that anticholinergic burden? I had one patient in particular that I could not elevate the dose to a significant level because the sedation was so high and he just wanted to sleep all the time. And he felt really groggy. He didn't feel himself. He felt like he was in a fog.
Mm-hmm. Indeed, clozapine's major side effects in terms of day-to-day side effects are mediated by its being an antihistamine. It's actually an inverse agonist at histamine 1 receptors and is potently anticholinergic. Both of those have sedating effects. Usually there is some adaptation to those effects as people take the drug. For some individuals, however, the adaptation is incomplete. And certainly those are, particularly at higher plasma concentrations, those often become the limiting side effects of clozapine. It's also a very robust alpha and adrenergic antagonist, which is why we have to titrate it slowly. If people got a very large dose of clozapine initially, they would be hypotensive and likely would faint.
One thing I was listening to Dr. Myers talk about this, and he talked about reducing the anticholinergic burden that's already there. And with this particular patient, he was also on anafranil for OCD, which is a heavily anticholinergic. Do you think that might have been one of the big issues for why he couldn't tolerate Clozaril on top of that?
Yeah, certainly it could be. Anafranil is among the most anticholinergic of the tricyclic antidepressants, although it's used mostly to treat OCD. It also is an antihistamine, so you get additive effects in both those areas. One of the reasons we worry so much about overall anticholinergic burden with clozapine is actually, when people think about serious adverse effects, they most often think about severe neutropenia. However, with current monitoring, the mortality rate from severe neutropenia in the U.S. is 1 per 10,000, so it's relatively low. The far more dangerous long-term risk with clozapine is constipation and bowel obstruction. That's actually resulted in a much larger number of deaths than the drug's ability to suppress neutrophil production. And for that reason, we usually advise people to try to avoid or minimize other drugs with anticholinergic effects as much as possible in clozapine-treated patients.
Yeah, I was reading it's like 60% of people on clozapine will get constipation or somewhere around there.
The package insert says 14%, but that's likely an underestimate because they only, in the package insert, they only recorded those cases where people complained spontaneously. They didn't ask them. And indeed, if you ask people, even for those people who are sort of doing okay, they'll tell you, they don't go to the bathroom as often, and it's not as easy as it used to be.
I once helped a hospitalized patient have a bowel movement through various, several drugs that we had to give her to have a bowel movement, and she was the happiest person who ever met the morning after she had the bowel movement. So,
indeed. One of the things we've recently done as a group, the PRN group that I belong to, one of the things we've done for the Department of State Hospitals is actually write a protocol for clozapine-treated patients recommending how to approach bowel management. Essentially, everybody who gets put on clozapine at the very least gets a stool softener like Docusate 250 BID. The majority of people get on top of that an osmotic laxative, most often polyethylene glycol. If those two things don't work, then they have added to that an irritant laxative, like Biscadil. If those three things don't work, then usually the irritant laxative gets replaced with a secretory laxative like lubiprostone or pleconatide or linaclotide.
I've heard more fiber does not help. It can actually make it worse.
No, indeed, one of the chief recommendations with treating or managing somebody's tendency toward constipation who's on clozapine is to avoid the bulk laxatives. On average, the typical average bowel transit time is right around 24 hours in most people. If you take a person who normally has a bowel transit time of around 1 day, put them on clozapine at therapeutic doses, the average increases to about 110 hours. And of course, that means the stool sits in the colon and dries out, becomes hard. Well, if you add something like psyllium to that, it's a great recipe for making what is essentially concrete.
Oh, dear. Okay, let's go through some of the other side effects in treatment. So I have a lot of patients complain of drooling, and that can be nauseous even more for the spouse or the loved one. So any thoughts on
Yes,
first line?
Yes, there are several ways to manage that. First caveat is try to avoid use of systemic anticholinergics to decrease salivation, because of course that's going to increase the constipation risk. It's essentially primarily the metabolite of clozapine, desmethylclozapine, also known as norclozapine, that's responsible for the sialuria. It, unlike clozapine, is actually an agonist at all 5 muscarinic receptors, and basically causes the parotid glands to produce excessive saliva. First approach is, in most patients, you can dose clozapine all at night, so you can reduce daytime salivation that way. Next step is to use topical anticholinergic medications, either ipratropium nasal spray, 0.3% or 0.6%, applied sublingually, not in the nose, under the tongue, with a swish and spit after a few seconds. That often will serve to dry up the parotid glands. An alternative to that is 1% atropine drops, 2 or 3 drops under the tongue, again with a swish and spit. Either of those can be given up to 2 to 3 times per day in more severe cases. Something that psychiatry is beginning to borrow from neurology in this regard, though, is injection of the parotid glands with botulinum A toxin. For primary neurologic sialuria, neurologists have been using botulinum toxin now for a number of years to decrease excessive salivation. As it turns out, it works for clozapine-induced sialuria as well. This is an injection with a very tiny needle, a 32-gauge needle, small volume, into each parotid gland. The effect lasts for about 3 to 4 months. And indeed, it was one of the researchers who established its use for clozapine-induced sialuria is currently on faculty over at Loma Linda University.
Oh, wow. Who's that?
Actually, I don't remember his name, unfortunately.
It's okay.
But I can send you, in the context of the podcast, I can send you copies of the articles to post along with the presentation.
Yeah, as always, we'll put all the articles that he's talking about in the resource library, so you can, and the notes will be on my website as well. So, okay, let's go into seizures. So there's a increased risk of seizures with clozapine more than other antipsychotics.
Yes.
And I've heard the Depakote is the treatment of choice for the seizures. Would you add anything to that?
Both of those are accurate. Clozapine lowers the seizure threshold more effectively than other antipsychotics. All of them lower seizure threshold. It's just better at doing so. Primary risk factors are the rate of titration. If you titrate too quickly, you're more likely to induce a seizure. And this is an area where the package insert is pretty good, starting at 12.5 milligrams and then 12.5 milligrams BID, titrating slowly so that at the end of the first week, you're up to about 100 milligrams. And then week 2, another 100 milligrams, so that by the end of week 2, the patient's taking 200 milligrams of clozapine. And then after that, being sure that no single dose increase is bigger than 50 milligrams until you get up to your target dose will help mitigate against risk of seizures. Also, as people get to higher concentrations, usually greater than 700 nanograms per milliliter, there's an increasing risk of seizure induction, often with the heralding sign of myoclonic jerks. If the patient begins to exhibit myoclonic jerks, it's a good warning that they may be on their way to either a myoclonic or tonic-clonic seizure. Having a seizure, however, is not a reason to discontinue clozapine. It is a reason to introduce treatment with an antiepileptic. And as you pointed out, the first choice usually is valproic acid, very effective, very broad spectrum. If there are reasons not to give valproic acid, often the second choice is levetiracetam or Keppra.
And let's go back to sedation. I want to hear your thoughts on treatment of sedation. We already talked about trying not to give more anticholinergics than necessary. I'm wondering what your thoughts are on like Concerta or modafinil.
People have used Concerta successfully, or if not Concerta, even for those who have just a hard time waking up, immediate release methylphenidate. Unfortunately, modafinil and nudafinil have both been tested, and at least in controlled studies, they don't do any better than placebo in terms of reversing clozapine-induced sedation. So that at least in terms of groups, modafinil and nudafinil don't appear to be effective treatments. Having said that, I have seen individual patients who responded to those two drugs in terms of clozapine-induced sedation. So it may be worth a try, but with the caveat that it's not effective often enough to produce good controlled data. The other thing people can do, and that sometimes people don't realize, is that once the titration of clozapine is finished and the person's alpha receptors and acetylcholine receptors and histamine receptors have accommodated to the drug, in the vast majority of people, it can be consolidated to bedtime, permitting the person to have a lower plasma concentration during the waking hours. That does not appear to affect the drug's efficacy, but can help the person be a little more awake in the daytime.
Okay. Yeah, that's what I usually move it to nighttime. And I have one patient also on Concerta, and the person has been able to get through school and do really well, function at a high level, going to a graduate school. Mm-hmm. And really has been helpful for him.
Well, the good news is since indeed clozapine exerts its benefits for psychosis, not via dopamine blockade, increasing dopaminergic input to the frontal lobes is not, in essence, getting into a tug of war with clozapine itself.
Okay, what about agranulocytosis?
Okay, agranulocytosis, in the case of clozapine, unlike chemotherapy drugs, it's an autoimmune process. Its highest risk is right around 1 month of treatment. It reaches a little over 1% risk, and then it begins to decline so that by the time people are out to a year of treatment, that risk is down to right around 0.38%. By the time they're done with 2 years of treatment, the risk of clozapine-induced severe neutropenia or agranulocytosis is down to about 6 per 10,000 cases. So the risk does decline over time. Currently, the FDA defines severe neutropenia for clozapine as an ANC count of less than 500 cells per cubic millimeter. If that occurs, then clozapine needs to be stopped. An important caveat in stopping clozapine is to give the person a tapering dose of benztropine or other anticholinergic. Benztropine is the most common, usually starting at 2 milligrams BID and then gradually decreasing by around half milligram of the daily dose per week. That's to prevent cholinergic rebound from the loss of clozapine's anticholinergic effects. Such rebound can cause a fairly severe delirium along with nausea, vomiting, diarrhea. So not a very pleasant syndrome.
This is some good nuance here.
It's important the other important and probably the most important element of treating clozapine-induced severe neutropenia is to give the person filgrastim, the synthetic analog of colony-stimulating factor, a 480 microgram dose subcutaneously as soon as it is available. That's the maneuver that's actually going to save the person's life. Daily filgrastim is needed initially. The average length of time to response is about 12 days. So the bone marrow there's going to be a delay before the bone marrow responds, which is why it's important to put the person in a situation where they have reverse isolation and also very careful monitoring for any evidence of infection. Infection or temperature above 100.4 degrees Fahrenheit increases the mortality rate from 1 in 10,000 to between 5 and 10%. Something that used to not be allowed after somebody had severe neutropenia was rechallenge, because this is autoimmune. There is an immune memory, and it's very likely that re-exposure to clozapine will ramp up antibodies against the neutrophil progenitor cells, causing the whole thing to happen again. The FDA now does allow rechallenge if clozapine is really the only viable treatment option. There have been 2 studies published looking at can you do that provided you give the person careful monitoring and ongoing filgrastim support, 300 micrograms a week to twice a week. And the answer is 70% of the time, yes. You can get away with rechallenging the person with clozapine, which is an important new development for those people for whom literally nothing else is a viable option.
So you would rechallenge. How long would you wait to rechallenge again?
You want the bone marrow to recover. That is, you want the absolute neutrophil count to be above 1,500 cells per cubic millimeter. Usually this is going to be a good 4 to 6 weeks after the person became neutropenic. And at that point, you can indeed reinitiate clozapine, but reinitiate it with ongoing filgrastim treatment. Currently, at DSH Patton, we have 3 patients who require ongoing filgrastim.
Oh, like every day?
every week.
Every week. And because they had the neutropenia
Yep.
once, and then you reach out, and then you put them back on.
Yes, indeed, because these are people for whom, frankly, the other antipsychotics are a waste of time. No effect on their psychosis. These are also very ill people who are at great risk of harming themselves and harming other people if their psychosis is not adequately treated. And indeed, that's another important issue with clozapine, as we've discovered in recent years, I think 2016 or 17, Yamashiro et al. In Japan published a study in which they looked at, well, do the effects of clozapine begin to fade if the person is treatment resistant long enough? And indeed, they found that clozapine's efficacy begins to decline after about 2.8 years of meeting the criteria for being treatment resistant, which is an argument that in those people who don't respond to other antipsychotics, we should be thinking about clozapine sooner rather than later.
Yeah. Yeah. And I imagine that's because just being chronically psychotic is damaging to the brain.
Yes, there have been a number of studies looking at that ongoing uncontrolled psychosis causes further deterioration of the brain. The loss is highest early in the illness, after onset of overt psychosis, loss of 2% of brain mass per year for the first 5 years, or 10% of the person's brain. Fortunately, it slows down after that, but it doesn't drop to zero. And there's a positive correlation between the number of acute psychotic episodes and the degree of loss of brain mass.
And does clozapine decrease that, or does it continue?
It decreases that, and indeed, because clozapine is more effective than other antipsychotics, it appears to slow progression of schizophrenia more than the other antipsychotics do. Although, to be fair, all of the antipsychotics as a group have had an effect on schizophrenia that has been substantial. If you go back and read Emil Kriplin's original papers, most of his patients reached a relatively vegetative state by the time they were in their 40s. People sometimes still reach that state, but now it's in their 6th or 7th or 8th decade.
Mm-hmm.
So we've slowed down the illness. We're still a long way from being able to reverse the pathophysiology, but among the agents we have, clozapine is probably the best and is one of the most neurotrophic of the antipsychotics.
Yeah, this is where I get passionate about lifestyle, strength training, cardio, and healthy diet with this population, because those are the main things that prevent dementia from progressing. Exercise, cardio, strength training, that's where I think the best science is for dementia prevention.
And there is some evidence supporting that cardiovascular exercise in particular may also be beneficial for schizophrenic patients. A very difficult population to motivate. One of the major health risks for people with schizophrenia is they tend toward a sedentary lifestyle. And on average, people with schizophrenia live about 20 years less than the general population. One of the findings with clozapine, actually at the Maudsley group in London, was that clozapine, despite all of its health risks, actually tends to prolong life in schizophrenia. At first they thought that, well, maybe that's just because these people are getting monitored more often, but they controlled for that statistically and indeed found that no, it was the clozapine itself that was producing greater longevity, likely because, being actively psychotic is a dangerous condition to have for your overall health.
Yeah. And I would say this also brings up the topic to me about the importance of the Therapeutic Alliance, and having a long-term psychiatrist can be so important for this population because they really will get easily paranoid and exile family members and people and friends if they're psychotic. And so having a trusted doctor they can go to, although it can be very difficult to build that trust, I think it's so important because then they actually take the medications, or they're more likely to take the medications if they have a strong therapeutic alliance, and then they're more likely to continue in treatment, which is a big issue with this population.
Yes, indeed it is. In fact, non-adherence is probably the major factor in terms of treatment failure for the schizophrenic population at large. Invariably, when they've done careful studies of adherence, and even giving people a bit of fudge room, saying, well, if you take 80% of the doses, we'll count that as adherent. The adherence rates for oral antipsychotics is consistently less than 40%. That can be partially addressed with the long-acting injectable antipsychotics. Of course, because of its health risks, clozapine is not available as a long-acting injectable. It does, however, come in a variety of dose forms. It's available as tablets, wafers that dissolve in the mouth, as well as in liquid form.
Yeah, and this is where, like, as an outpatient psychiatrist, what I do is I look at how often they need refills, and if they're not requesting refills, then they're not using the pills as prescribed. And it gives me an idea, and I also utilize family members a lot in this population to really kind of monitor whether the people are taking the medications or...
Yeah, both of those are very important. The other item to promote is use of plasma concentration measurement.
Yes.
For two reasons. One, adherence. Obviously, if the person is taking the drug consistently, they should have fairly consistent plasma concentrations. And secondly, just to be sure that you're actually dosing clozapine or any other antipsychotic optimally. People vary tremendously with respect to things like absorption, rate of metabolism, so that, what's listed in the package inserts as the dose range for any of these drugs is an estimate based on average groups. It's not necessarily true of each individual. In fact, for some of the drugs, the variation across the entire population can range as much as 30-fold in terms of rate of metabolism, which is why measuring the drug to be sure you're actually giving it at the optimal dose is an important issue.
And this is something that I've really started doing since working with Dr. Cummings here, or collaborating, being mentored by him. And I would say, at first I thought genetic testing would be helpful, but there's so many factors leading to blood levels that are not measurable by genetic testing. And, genetic testing is not predictive of what the blood levels are for these drugs. And so getting a level, one, when they're not doing well, to see if you can continue to go up. And number two, when they are doing well, to see what blood level of something like clozapine actually gives you the effective dose. Because then when they're not doing well in the future, you can say, okay, I'm going to recheck their blood level, and lo and behold, look, it's so much lower because they started smoking more cigarettes. That lowers the blood level of clozapine, or so on and so forth. I don't know if you have anything to add to that.
Yeah, no, that's right, because there are a number of factors that can alter hepatic metabolism of drugs, either exposure to other drugs, smoking induces hepatic enzymes, or in some cases it may be the absence of something. I had a patient who loved grapefruit, and in grapefruit indeed inhibits 1A2, which is the primary enzyme responsible for catabolizing clozapine. Well, he decided to switch to oranges in the morning, and his clozapine level plummeted because he was no longer inhibiting the enzyme that catabolizes the drug.
Yeah, so this is where there's so much complexity that goes into it. Having a little bit of idea on P450s and what's going on can be helpful, but really checking the blood levels can help you catch things that otherwise you wouldn't catch and know how to monitor these things.
Yeah. Indeed, the genetic testing can tell you whether somebody's an extensive or a slow metabolizer with respect to a particular P450 cytochrome enzyme, but it can't give you the end result in terms of a particular drug concentration with the precision that simply measuring the drug itself does.
Talk to me about blood levels for clozapine. Like what are the ranges that you try to get someone in?
For treatment of psychosis, you're aiming for a minimum level of 350 nanograms per milliliter, and likely an initial target range of 350 to 600 nanograms per milliliter. If the person doesn't respond adequately within that range, meaning they still have symptoms, but they are tolerating the clozapine adequately, you can then gradually titrate upward because more treatment-resistant patients may require a blood level somewhere between 600 and 1,000 nanograms per milliliter. After 1,000 nanograms per milliliter, there's a diminishing return on further increases and essentially much greater increase in adverse effects without a lot more benefit for most patients. Now, having said that, there are rare patients who require clozapine plasma concentrations that are above the norm. We have 2 patients at DSH Patton who require plasma concentrations of right around 1,400 nanograms per milliliter, which is a truly heroic plasma concentration. Now, if the drug's being used for other purposes, such as treatment of criminality or violence in a non-psychotic person, they often respond to much lower plasma concentrations. At the Broadmoor in England, they did a study in 7 psychopathic patients and got a dramatic reduction in violence in all of them, with an average plasma concentration of 171 nanograms per milliliter. So depending on, it's like everything else, the amount required may vary by illness.
Yeah, let's jump into clozapine-induced cardiomyopathy, myocarditis. What is it? Both myocarditis and cardiomyopathy?
They are separate, but one can lead to the other. Acute myocarditis is estimated to occur in 2 to 3% of people who take clozapine. It's characterized by fever, chest pain or shortness of breath, and essentially the signs and symptoms of evolving congestive heart failure, edema. All of the cases reported worldwide have thus far occurred in the first 6 weeks of treatment, with 90% occurring in the first 4 weeks. So this is a very early risk of clozapine. When it does occur, the first step when it is suspected is to measure both troponin and C-reactive protein. Troponin that is twice the upper limit of normal reflects myocardial injury. And there are rare cases where the troponin does not increase, but C-reactive protein does, which is why the secondary measurement for inflammation is tested. If those things are positive, then indeed the person needs to be taken off of clozapine and they need an echocardiogram. And in the majority of cases, if the clozapine is stopped, the myocarditis resolves. This is a myocarditis that's mediated by increased eosinophils. Unfortunately, measuring the eosinophils by itself is not useful because about half of clozapine-treated patients show an eosinophilia. Most of those are benign, however. They're essentially not active eosinophils, so they don't mean anything. The inflammatory measures and then the echocardiogram are the important measurements in that context. If it is prolonged, the myocarditis can lead to a dilated cardiomyopathy. The other route to cardiomyopathy with clozapine is about 20% of people who take clozapine develop a persisting tachycardia. They don't have myocarditis, but they're tachycardic with a heart rate above 110 at rest. On an ongoing basis, that's a long-term risk for developing dilated cardiomyopathy. In such patients, it's fairly easy to treat. It can be treated with a beta blocker. The drug of choice often is atenolol because it does not cross the blood-brain barrier and it's cheap and has once-a-day dosing. And usually starting at low doses, 12.5 milligrams, with then titration as needed to get the person's heart rate under 100.
That's good. What do you think about treatment of the myocarditis?
The myocarditis, the main element of treatment is the discontinuation of the clozapine. There have been some groups who've looked at then giving also the person intravenous steroids to interrupt or suppress the inflammatory response. The jury is still out on whether that changes the overall course of the acute myocarditis or not. Hopefully in the next year or two, we should get some studies that'll shed some light on that. One of the problems, of course, in studying any sporadic adverse event is it's hard to put together a prospective study of something that happens here, there, and everywhere, and only rarely.
Yeah. Is there anything else you would really like us to understand about clozapine?
I think probably the chief take-home message I would give people is if you have somebody who's suffering from schizophrenia or schizoaffective disorder and they are not responding to what are clearly adequate trials of other antipsychotics, pursue clozapine with that person sooner. It is truly presently our gold standard for treatment.
Well, that is really a deep dive into clozapine. I hope that's been helpful to people who have been listening.
To finish up, I did want to give a plug. Jonathan Meyer, who is one of the physicians I work with in the PRN consultation group, has just written a Clozapine Handbook. It's one in the series of Stahl's handbooks. It has just been published by Cambridge Press and can be ordered from Cambridge Press. Presently, as of May 31st, it will become available through Amazon.
Have you read that? I know you.
I have, and indeed I helped edit parts of it. It is an excellent book. It deals with both the benefits and how to manage all of the various issues that can arise with clozapine. It's about 300 pages and is available. I think the retail price is just under $50.
Yeah, so I'm going to put a link to all these things in the show notes and on the website, and I will put the resources that Dr. Cummings talked about and I talked about, including good blood levels for the different antipsychotics in the resource library. And as always, I hope that you guys find this helpful. This one's a little bit more psychopharm than usual, but I think it's important, especially because in treatment-resistant schizophrenia, this is the go-to treatment that I use and other psychiatrists use, and we should all become experts in it for those treatment-resistant patients. So Dr. Cummings, thank you so much for coming on.
Thank you for having me.